Today's guest is Stephen Bright, PhD. Dr. Bright has worked as a psychologist within the mental health and alcohol and other drug field for the past 15 years.
Compared to other Western countries, Australia has the highest per capita usage rate of drugs like cocaine and also possibly MDMA.
He's dedicated his clinical and research career at Edith Cowan University to minimising harm related to drug use.
The nature of alcohol in terms of the way it disinhibits people and increases violence. If you see two people out in the street having a fight, you had to guess which drug they were on. Are they on alcohol or have they taken MDMA? Certainly not MDMA if they're punching up.
In this episode, you will learn about the current state of alcohol and drug use in Australia, including specifics related to cocaine and cannabis, the relationship between drug use and mental health, the current treatment paradigm for patients with mental health conditions, how entheogens or psychedelics could help certain patients, how decriminalisation and legalisation of certain drugs could reduce drug-related harm, and plenty more. I hope you find this exchange as interesting and thought-provoking as I did. As I understand it, you're a psychologist and an academic with an interest in alcohol and other drug use, finding ways to reduce drug-related harm, and psychedelic therapy for mental health. How did you become interested in all of these things, and what are the burning questions that you've been interested in exploring so far through your career?
Yeah, so I became interested in the alcohol and other drug area first off, and that was through my own personal experiences, through my social groups, my family, and essentially went to uni to become a psychologist to work in the alcohol and other drug treatment sector. And it was while I was working in the sector and also completing my PhD, which was really, my research at that point was really focused on why there was this discrepancy between the evidence when it comes to drug-related harms and what the common narratives are in the community and sort of how that's being portrayed in the media. Because I guess through my undergraduate learnings, I'd realised that the information I was getting through my studies was quite different to that which I was being exposed to in the community and being exposed to in the media. And it was essentially was questioning the utility of prohibiting drugs, and whether that actually does more harm than good. Whether there's alternative approaches than prohibition, things like decriminalisation, harm reduction, and just sort of unpacking that. And it was while I was working in Melbourne. I'd left Perth and I was working in Melbourne, still completing my PhD. I wanted to talk about the issue I was starting to see with new and emerging drugs back in 2009. So all of a sudden, these new drugs like mephedrone and alphabet soup were starting to emerge in the scene. And I wanted a safe place to talk about this because, given my PhD research, I realised if I talked about this at a mainstream conference and the media got wind of it, then these drugs were probably going to be banned. And as I was saying, I don't think prohibition is necessarily the best way of dealing with these issues. And so while I was in Melbourne, I just surreptitiously came across this conference called Entheogens Australis, which seemed really unique and interesting. So I chucked in an abstract. Abstract was accepted. And, I went along to the conference, and it was unlike any other conference that I'd been to. It was an outdoor event for a start. It was kind of like a cross between a festival and a conference. They had incredible speakers from all over the world, particularly speakers from the US that were talking about the re-establishment of psilocybin research at Johns Hopkins University. And I wasn't even aware that was happening. I'm meant to be an expert in this area, and I didn't realize the research had restarted again. And so it was not long after that I was introduced to Dr. Rick Doblin, who heads up the Multidisciplinary Association for Psychedelic Studies, he and MAPS have essentially been spearheading all of the research on MDMA to make it to make it a medicine that can be used in society, a mainstream medicine. And from there, so about over 10 years ago, that meeting occurred, and from there became really interested in the area. And the reason for my interest was just the data from the first clinical trial that Rick presented showed an incredible effect of MDMA-assisted psychotherapy on post-traumatic stress disorder. And in alcohol and other drug treatment, PTSD is the norm rather than the exception. So many people with substance use issues have concurrent PTSD or other sort of underlying trauma. And my experience was that the prognosis wasn't great for these individuals. So the idea of an alternative treatment that might be more effective than what we're currently doing was very appealing. And that's sort of where I picked it up from.
Yeah, you kind of just touched on one of the questions that I had for you, which was, I have to imagine there is a large overlap between drug use, drug-related harm, and mental health conditions. Is that the case?
Absolutely. And so a lot of people that experience substance use related issues have pre-existing trauma, and they're using substances as a way to manage the symptoms associated with their trauma, but it's other mental health issues as well. So depression, essentially psychoactive drugs are far more effective than the current arsenal that we have of psychotropic medications to treat things like depression. They provide instant relief from depression, but of course they're not treatments, they're just short-term fixes and actually exacerbate the mental health condition in the long run. So yeah, whether it's an anxiety disorder or depression or PTSD, there's the idea of comorbidity or coexisting mental health conditions with substance use disorders is the norm, not the exception.
There was a lot you mentioned there at the outset, and some things that I want to put a pin in and come back to, make sure we come back to revisit towards the end of this conversation, particularly decriminalisation and legalisation, and what that could look like. Before we get there, can you paint the picture for us of what does the current landscape look like here in Australia with regards to alcohol and other drug use at the moment, and how does this compare to other Western countries?
Well, compared to other Western countries, Australia has the highest per capita usage rate of drugs like cocaine and also possibly MDMA. So there's a huge demand for illicit drugs in Australia. And in terms of contrasting that with the legal drugs like alcohol and tobacco, significant numbers of Australians experience harm from alcohol, be it from harm they've experienced themselves as someone who's drinking or harm they've experienced from somebody else who's been drinking and assaulted them or something like that. So something like I can't remember the stats, sort of change, but it's somewhere around 1 in 10 or 1 in 25 people have experienced direct harm in the past 12 months. And that goes sort of against what the narrative is in the media. If the narrative in the media has really been over the last few years anyway, the ice epidemic, and that our hospitals are full of people with methamphetamine psychosis, and that absolutely is a problem. But if you go to any hospital in a metropolitan region on any Friday or Saturday night, there'll be far more people that are presenting with an injury or some sort of harm associated with alcohol than any other illicit drugs combined, all of the illicit drugs combined.
I think you mentioned there that Australia has the highest per capita drug use. Did I hear that correctly?
Highest use of cocaine and MDMA.
What do you think is driving that? Is it education? Is it supply?
I think there's I don't think we know, but I think there's lots of things that might be contributing to it, including just our culture in terms of, if we look at our drinking culture, that often is applied to the way people use other drugs. And our culture is one of, binge drinking and basically getting effed up, getting messed up. Particularly in young adulthood. And that is changing. There's cohort effects at the moment. Young people are drinking less than ever and are abstaining more than ever than we've seen since we've been recording data in Australia. But that culture, that binge drinking culture still remains. And I think For a range of reasons, people are turning to illicit drugs rather than alcohol, including the cost. It's a lot cheaper to go out and use MDMA as your drug of choice rather than binge drinking, particularly if you're going out and paying for expensive drinks in a club environment. So that's another reason for it. And I think we are fairly well off as a middle class society. So people have disposable incomes that they're able to spend on illicit drugs. So there's an incredible demand for drugs in Australia. We also pay more for our drugs than almost any country in the world, and that creates an incredibly lucrative business model for people that are supplying the drugs. That it's far more lucrative to bring drugs into Australia than any other country.
So is it simply a shift in terms of the choice of drug that people are using away from alcohol towards other substances? Or if we look back over the last, say, 20, 30, 40, 50 years and compare that to today, do we see increased overall drug use, about the same, or reduced?
Our data doesn't go back 50 years, but looking over the past 10 or 20 years, there's minor fluctuations, but there's no clear trends in terms of increasing drug use. So it's remained relatively stable. And some people have suggested that the cohort effect we're seeing with young people in Australia not drinking, their response will be, oh, yeah, that's because they're using other drugs. But we're not really seeing an uptake in young people using other drugs. So that's not really a good explanation for why young people are drinking less. Yeah, things have remained relatively stable. Even with methamphetamine, use of methamphetamine's gone down in the past 10, 15 years. It hasn't gone up, despite what you might read in the newspaper.
So why is it that you think the media is not accurately portraying the current climate, current situation here and what you're seeing in the evidence?
Well, if we go back many years, 60, 70 years, when the first concerns about tobacco smoking and cancer were being raised in the medical literature, many newspapers didn't report on this because they had sponsorship from tobacco companies. And so there was a vested interest in them keeping quiet about the story, or at least, putting it on page 16 and not on the front cover of the newspaper. And we have a similar situation today with alcohol. A lot of revenue from media companies comes from alcohol companies, and obviously they have a vested interest in not perpetuating a narrative that alcohol is causing significant harm in the Australian community. And on top of that, I think it goes against, if you speak to the average journalist, that the average journalist probably enjoys a few drinks and doesn't see that alcohol is a particular issue for them. And we tend to scapegoat other drugs and people who use other drugs because it takes the heat off our own drug use by focusing on that other drug use. And likewise, I think that's why the narrative around cocaine use, which has actually increased, we were talking about changes. One distinctive change has been the increase in cocaine use, such that we are now number one in the world per capita in terms of our consumption. Cocaine tends to be used by people who are more well off, so be it lawyers, magistrates, journalists, etc. And again, like alcohol, if cocaine is your drug of choice and you're a journalist, then you're probably not going to want to cover that sort of story. It would kind of go against your own personal vibe of what's the right thing to report on.
You say Australia has the highest per capita cocaine use in the world. I think that might be news to some people. Has anyone quantified that? When I think of alcohol, often there's statistics thrown around about the average number of standard drinks someone has in a week. How much cocaine is the average Australian having per week?
It is difficult to quantify that. So there's two ways that we can get data on population-based usage. The main way that we obtain that information, and the traditional way of obtaining it, is through self-report. So we do a national survey every 3 or 4 years, and survey some 20, 30,000 Australians from all different parts of Australian society so that we can make generalisations to the population based on that. But of course, there's limitations in getting information through self-report. There might be underreporting, for example, because as humans, we tend to over-report good things like charitable donations. We tend to underreport bad things like how often we eat junk food or use cocaine potentially. The other way that is more recently being used to sort of gather this information is wastewater analysis. So they researchers are taking samples from sewerage and looking at how much cocaine and other metabolites of drugs are in the samples, and from there they're trying to estimate population parameters. But again, there's some limitations in that because, of course, not everybody uses cocaine, and even what goes down the toilet isn't necessarily a representation of what people are using. For example, if I'm carrying a kilo of cocaine at my house and the police turn up at my door, I'm probably going to flush it down the toilet, and that's going to end up in the wastewater analysis, perhaps inflating the amount that we think the average person's using. So I guess the answer to your question is it's very difficult to know sort of what the average Australian who uses cocaine, how much they're using, and we've got an idea of frequency, how frequently people are using. Most people aren't using it more than once a month. It's an occasional thing. It's not a regular thing. But we don't. It's hard to get good data on this.
There's some interesting analyses done in the nutrition space where there's observational studies where there are food frequency questionnaires, but sometimes the researchers get like a subgroup of people and do blood work, for example, and look at essential fatty acids in the blood that we know that the body can't produce. They must be coming through diet. So it's kind of a neat way to verify that what you're seeing in the questionnaire data is accurate. This is just a question for my own personal interest, but how long is cocaine in our system, and could a similar thing be done there with blood or with hair samples or something?
So pretty much all drugs, except for cannabis, which I'll talk about in a moment, pretty much all drugs are eliminated from the human body within about 3 days. So it does make that sort of testing problematic. One way of overcoming that is testing hair. I'm not clear on the accuracy of that, but that's certainly one way around that problem. And as I said, cannabis is a bit different because cannabis is lipophilic, which means it likes fat. It can be stored in fat, whereas most drugs are more they tend to be more water soluble than fat soluble. And as a consequence, cannabis can stay in the system for up to 3 months after a person's last use. So for someone that's just smoking a joint, once a year, it might stay in their system for a week or 2 weeks. But somebody that's using cannabis regularly, it will stay in their system for up to 3 months. And that creates problems in terms of drug testing at mine sites and places like that, because we've seen a shift away from cannabis to other drugs which stay in the system for a shorter period, for example, like cocaine. So people who are using cannabis previously, once drug testing is implemented, they shift to a drug like methamphetamine or cocaine, or even some of the new and emerging drugs, knowing that the drug tests that they might have to do in the next couple of weeks won't detect some of these new drugs. And that's essentially why we saw synthetic cannabis take off, in 2010, 11, 12 in Australia. It was because many people were looking for a way to get a cannabis-like effect, but without it resulting in a positive drug screen for cannabis. Be that, it's not just mining sector; it's other workplaces do it, but also courts do testing, including family courts, so people in custody disputes, et cetera, et cetera. So. I've sort of gone off on a tangent there about the problems of drug testing.
Is synthetic cannabis, excuse my ignorance here, is that considered an illicit substance, or is that completely legal?
Well, as a consequence of what went down in those sort of 2011, 12, 13, 14 I think 2016 in Victoria, or maybe a bit earlier here in Western Australia. I was in Victoria in 2016. That's why I remember that date. Essentially, all of the states and at the Commonwealth level, there's been a legislative change made that's often called a blanket ban on psychoactive substances. And depending on your jurisdiction in Australia, the blanket ban is slightly differently worded. But in general, this law prohibits anything that has a psychoactive effect, excluding alcohol, tobacco, caffeine, drugs approved by the FDA, herbs and spices, because there's certain herbs and spices that are psychoactive, and other states might even regulate based on the chemical structure. So if it's similar enough in chemical structure, then it would be considered an illegal drug. And an example of that is Queensland has one of the strictest blanket bans, meaning that a chemical called tyrosine, which is contained in cheese and avocados, is technically considered illegal in Queensland. And I worked with a lawyer a couple of years ago. I'm pretty sure it was Greg Barnes, where we did some reporting around this and the absurdity of the Queensland legislative change, essentially banning cheese and avocados. And the Attorney General in Queensland came out stating that, obviously that's not the intention of the law, but ultimately, when you a law that's being put in place should be fairly black and white. There shouldn't be shades of grey, like, okay, avocados are technically illegal, but we're not going to prosecute anyone for that because that's silly.
Yeah, what a strange world that would be if you were pulled over by police because you had a tray of avocados. So cocaine use is increasing. Cannabis use, is cannabis the most used drug outside of alcohol?
Correct. Yeah, correct. It's the most used illegal drug, and you're probably right. It's probably the most used drug outside of alcohol. Maybe some prescription medications might come close. But essentially, the most used drug in Australia is caffeine, followed by alcohol, and then as you say, cannabis. And rates of cannabis use remain fairly stable. About 1 in 3 Australians have tried cannabis in their lifetime, and 1 in 10 or slightly more than 1 in 10 have used cannabis in the past 12 months.
And do we know much about that population? Are there characteristics about people that are regularly using cannabis that would distinguish them or separate them from people who are not, whether that be socioeconomic status or mental health or other?
Yeah, all of those things predispose an individual to regularly use cannabis. So, lower socioeconomic status, pre-existing mental health condition, all predispose somebody to end up using cannabis on a regular basis. But there's looking at that population versus the general population, there's not a whole lot of big differences there. We know that regular, heavy, long-term cannabis use does impact cognitive functioning. So, people's functioning on IQ tests will be lower, but it tends to be a temporary thing. And if the person, provided they didn't start at 8 years of age, it tends to be reversible, which is not the case, say, with alcohol. Alcohol causes permanent brain damage. Cannabis, the way I like to describe cannabis and its effects on the brain is it's a bit like putting Jell-O in the brain. Like, it slows everything down, but once you clean it out, the brain fires up and it's functioning as per normal. I think clinically speaking, one of the most concerning things about people who regularly smoke cannabis is just the amotivation. People become less motivated to get off the couch and do things. And it's not only, I guess, when I was saying that, I was thinking more about, productivity, engaging with society, paying taxes, all of those sorts of things. But it's even more than that. It's things like physical activity. We know sedentary behaviour is it's correlated with nothing good. That's for sure.
Right. So it can have a ripple effect and start to affect other aspects of one's lifestyle, which then affect quality of life, risk of disease, etc. You mentioned heavy use. What would heavy use, how would we define that? What would that be?
Heavy use would be daily use for a start. So using on a daily basis, using multiple times each day. And typically with regular heavy cannabis use, people start to experience problems with sleep. So they without cannabis, they can't sleep, and they may wake up during the night to smoke some cannabis to be able to get back to sleep again.
How does someone kind of break that cycle if they are using cannabis to sort of fight or push back against insomnia and it's working, but they would rather not have to rely on cannabis? What are the steps that someone might go through, or things that you've done with patients that you've worked with clinically?
Yeah, I think there's lots of different options, and so starting at one end of the spectrum, which is the least invasive, I guess, would be to take a harm reduction approach and access cannabis through a medical regulated source, and perhaps changing the route of administration from either going from smoking to vaping, which is far less harmful, or ideally moving to an oral route of administration, because the way cannabis works when it's consumed orally is quite different to the way it's used when it's vaporized or smoked. And consequently, people find that they use far less frequently when they're taking it orally. So I guess that's one end of the spectrum, and the other end of the spectrum would be looking at abstinence. And traditionally, detoxification services in Australia haven't accepted people for cannabis withdrawal if they want to cease completely. So usually it's done by the individual in consultation with a general practitioner and probably a nurse working for an alcohol and other drug treatment service, or an AOD counsellor or psychologist like myself. Where the GP prescribes minimal amounts of medication, things like temazepam or Valium, to help take the edge off for that period of withdrawal. Because, as I was sort of saying earlier on, because cannabis is lipophilic and stays in the system for much longer, the withdrawal from cannabis is quite protracted. So with most drugs, withdrawal peaks after 2 or 3 days of ceasing use. Though with cannabis, it doesn't peak till about 10, 12, 14 days after the person stops. So it's far more gradual, but it's far more extended. And that's why detoxification services have typically not taken people for cannabis, because they're set up for a 2-week stay because that's what works for most other drugs. But of course, they're then discharging people with cannabis while they're peaking in terms of the withdrawal. And so most of the time it's being managed in the community, as I've said. During the peak of synthetic cannabis, though, I worked with a number of detoxification services to ensure that they were able to take people in that were wanting to abstain from synthetic cannabis, because it was a completely different drug. Some people have said it shouldn't even be called synthetic cannabis. Essentially, these are synthetic cannabinoid receptor agonists, novel drugs that are being put on some parsley or whatnot, an inert herb to be smoked. And consequently, like the traditional drugs, the withdrawal peaked at about 2 or 3 days. And for some of the newer generation synthetic cannabinoid receptor agonists, the withdrawal was quite severe and could include things like seizures, which is where you really want medical involvement. When we're talking about withdrawal from drugs, the most dangerous drugs to stop taking are alcohol and benzodiazepines, things like Valium and temazepam, because they cause these seizures. And so seeing that in another new drug that was emerging was a real concern at the time, and which was why we really advocated for detoxification services to take on these patients, because they were at an elevated risk of experiencing something going wrong medically if they didn't have that medical supervision.
You mentioned that vaping is less harmful. Tell me a little more about that, and I presume that there have been scientific investigations looking at the different risks posed by more traditional smoking versus vaping. When I kind of just think about this, and this is not scientific, just observation of people in society and friends that vape, one thing that kind of worries me is that because it is a little more acceptable and convenient, that perhaps the person ends up actually inhaling a lot more tobacco or a lot more cannabis than they otherwise would have.
Yeah, I I would normally try to avoid talking about vaping, but I open up the conversation here, so I'll wear that. The reason I try to avoid it is in my 20 plus years of working in healthcare and public health, I've never seen an issue divide my community the way vaping has. There are, staunch advocates for this being a life-saving intervention for smokers. And then on the other side, there's people concerned about so many young people taking up vaping and it becoming basically the new norm, the new smoking. And what do we do about that? And, I see both positions. I think absolutely it can be a life-saving intervention. It's you asked about the research. The British Medical Association has concluded that vaping nicotine is 95% less harmful than smoking tobacco. So that's a significant reduction. But I also really understand the other side's concerns as well. I don't want young people to be dependent on nicotine. I think we've got a huge problem in Australia with black market vapes being distributed to young people in schools. Schools across Australia are trying to deal with the issue. Government's trying to deal with the issue. Unfortunately, I think we've left it too late. It's already in the community now. Australia needed to act 10 years ago, not now. The US and the UK all regulated vaping 10 plus years ago. The Australian TGA wasn't willing to do that because they were concerned about, basically they said, well, there's still 5% harm. 95% less harmful still means 5% harm, and we're not willing to take that risk and be responsible for that. But in doing nothing, that inaction has now led to the current situation where, because there was no regulation in place, a black market emerged, and once the black market is set up, it's very hard to shift that. And I'm not real optimistic about where this is all going. I think we're going to see vaping in the community for a long time to come now.
Yeah, and they're making them to taste so good, right? Which, there's parallels there with the food industry and marketing early in life to kids. And then once they begin to develop those habits, they're very hard to change later on in life. You mentioned earlier that there is an overlap between drug use, drug-related harm, and mental health. What is the current state of Australia's mental health? Are we doing better or worse than decades gone by? I think, sometimes you hear in the media that there's a mental health kind of pandemic or epidemic. Is that true, or is it just that we're getting better at screening and we're being more proactive and we're educating people to feel more comfortable about their struggles, talking about their struggles rather than suffering in silence?
I think it's a real mixed bag. I think in many respects we're doing far better than we were when it comes to mental health. There's far less stigma associated with it. The way I see my students talking about mental health in class and even disclosing about their own mental health issues or medications that they're taking, that wouldn't have happened 20 or 30 years ago. So yes, on one hand, I think we're doing a lot better. I do think the so-called mental health crisis, a bit like the ice epidemic, is something that is overstated. And to be honest, I'm probably haven't thought about it enough, but I'm not sure where the vested interests are there for perpetuating that narrative. I think part of it comes from, the healthcare professionals like myself, particularly those working in private practice, arguing that we need more support from the government to provide funding for people to access their business, their psychological services. But yeah, it definitely has been overstated. The data isn't showing that there's been a significant increase in mental health issues in the community. However, it's getting harder and harder to access mental health services. So I'm not sure if the demand is increasing or probably it's a combination of demand increasing without adequate increase in supply of mental health services. And consequently, wait lists to access psychiatrists or even some psychologists are getting up to 6 or 12 months now to be able to see someone, which simply isn't good enough. When a person is reaching out for help, we need to provide that help as soon as possible because people's perception of their situation and their readiness to change fluctuates incredibly. And so when people are reaching out, they're ready to do something. Now is the time to engage with that individual, not put them on a wait list for 6 to 12 months. And after which time, unfortunately or fortunately, depending on how you look at it, their mental health condition may have improved significantly just spontaneously. That's the nature of some conditions. Like a depressive episode may lift on its own without intervention. Obviously, many times it requires intervention, but that's a pretty sad state of affairs if people are getting better just because we don't have the capacity to see them in time.
So what can be done in that space to ensure greater and earlier access to psychiatrists and psychologists?
It's a huge problem. I don't have an answer, but I can explain some of the nuance in terms of the problem. So both with psychology and psychiatry, there are a number of bottlenecks in terms of the training that's required that people have to do to be able to work in the community as those practitioners. So with psychology, for example, people enroll in an undergraduate degree, a three-year degree, and you might have, 400 students each year enroll in that degree. But that you need more than that to become a psychologist. You need at least 5 years of study. So then at the fourth year, there's only 40 places. So only 10% of those 400 students will get into fourth year. And then fifth year and sixth year is even more competitive. So the pathway I went through was a 6-year pathway. And it was bloody competitive when I went through it 20 plus years ago. And it's just gotten so much more competitive. I have former honours students, so fourth year students, that have travelled around the country to secure a place in a clinical training program, which was unheard of when I went through it 20 years ago. And the reason there are limited places is because there's not enough practitioners in the community to supervise people that are in these training programs. So you can see it starts to create a vicious cycle. We don't have enough places for people because we don't have enough practitioners in the community, and we're not increasing the number of practitioners in the community because we can't push enough people through these courses. And it's basically the same with psychiatry, but with different points in the bottleneck, but this same problem where very few people actually are able to get through and work as a psychiatrist.
Maybe technology is the answer, AI, to help kind of alleviate that bottleneck.
Yeah, I think solutions that are outside of the box like that are what are required, because it is this self-perpetuating problem, and I don't know anybody that I've spoken to that's got a clear solution to it. So, yeah, I think it's some out-of-the-box thinking is going to be required, because if we don't do something soon, the problem's only going to get worse.
Hey friends, the scientific evidence on lifestyle habits that lead to longevity is clear. Now it's time to put this knowledge into action. I'm excited to announce the Living Proof Longevity Challenge, a 12-week program to build evidence-based lifestyle habits to optimize longevity. My team and I have transformed over hundreds of hours of conversations with experts on aging, nutrition, and exercise into a life-changing 12-week program that will challenge you to develop habits that lead to a longer, better life. This is a unique opportunity to gather health data about yourself that has the potential to change your life for the better. You'll start by testing 10 longevity biomarkers that tell the truth about where your longevity stands right now, today. Following that, you'll get a personalized longevity score to guide your 12 weeks of habit building that will boost your score and improve your biomarkers for the better. After the challenge, you'll retest your 10 biomarkers and see the proof of how powerful these science-backed habits really are. Head over to theproof.com/livingproof to download your zero-cost copy of the Living Proof Longevity Challenge today. That's theproof.com/livingproof. Look forward to joining you on this journey. Okay, so let's assume that I have access to a psychiatrist or a psychologist, and let's assume that I think I have depression. When I reach out to a psychiatrist or a psychologist and I get a consult with them, what does the typical treatment journey look like for someone today? I think earlier in the conversation you mentioned that we need to have more tools, and perhaps this is where your interest in psychedelic medicine sort of stems from. But I'm interested here in what the current paradigm looks like. What is evidence-based sort of best practice for someone who presents currently in Australia with a mental health condition?
I think at the moment in Australia, there's a discrepancy between best practice and what's actually happening on the ground. So most people with, using the example with major depressive disorder, most people with depression are going to access help through a GP. It's primary health care. It's the first point of call. And unfortunately, many GPs will respond to a patient presenting with depressive symptoms by prescribing an antidepressant medication. We've talked about the per capita use of cocaine. The per capita prescribing of antidepressants in Australia is high. I'm not sure where we're ranked in the world, but we'd be in the top 10. We consume lots of antidepressant medication, and antidepressants are effective for people with severe depression. In fact, they can be life-saving. It can be the difference between someone taking their life and not taking their life. So these are absolutely life-saving drugs, but they're being overprescribed, and they're being prescribed to people that might not even have depression. They might have a situation that's leading them to feel stressed and anxious and stuck, but they're actually not depressed. It's situational, and providing them with an antidepressant drug is not going to solve the problem. They need to actually fix the problem that's causing them to feel that way. And one of the problems with antidepressant medications is they can be quite difficult to come off. So a number of my patients have tried to come off an antidepressant and not been able to come off, not only because of the depression relapsing, but because of other symptoms caused basically withdrawal. But we don't call it withdrawal when we're talking about antidepressants. Instead, we've come up with this medical euphemism called discontinuation syndrome, which is it's essentially the same thing. So yeah, I think that's a concern. And then comparing that with best practice, and look, there are some good GPs out there that the medication would not be their first line of treatment. So I just want to make that clear. There's certainly not all GPs are doing this. And to be fair on the GPs that are, we live in generation medication. People go to a GP and they want a medication. If you don't walk out with a script and you've paid for this appointment, you're probably going to feel like you've been hard done by. And these doctors are trying to run businesses. So I really get that. But best practice would be to set up a mental health care plan with the person so that they're able to be referred to a psychologist to engage in talk-based therapies, so cognitive behavioural therapy or any other based psychological intervention. And for most people, that psychological intervention is all that's required for their depression to remit. Some people have treatment-resistant depression, and that's where things like these new treatments with psychedelics are showing potential promise. But essentially, whether it's depression or PTSD or substance use, the first line treatment should always be an evidence-based psychotherapy, and then medications can be used to augment that. So we know that people do better. So people that are just prescribed the medication will see some improvement. People that do the evidence-based psychotherapy will see some improvement, maybe some more improvement. And if you combine them together, you get even more improvement. So if somebody's got quite severe depression, maybe the GP then needs to both do a referral to the psychologist via a mental health care plan and prescribe some medication. And if none of this seems to be working, then the GP can make a referral to a psychiatrist.
You said most people will get benefit from psychotherapy. So cognitive behavioral therapy being an example of psychotherapy. Do you have a sense for what percentage of people are slipping through the cracks where the current treatment approach, best practice, psychotherapy using cognitive behavioral therapy and other therapies, what is the percentage of people with depression or anxiety or PTSD that type of treatment is not helping or not helping enough?
Yeah, so it's very much dependent on the condition. So with some mental health conditions, we have very effective treatments. So psychology has learned how to treat phobias and panic disorder very well. Response rates upwards of 90%. So less than 10% of people are not responding to these treatments. And I guess, phobia may be something that's less debilitating, but panic disorder is essentially when somebody has a phobia of their own internal sensations. Their experience if you have a phobia of spiders and you see a spider, you're having a panic attack because you see the spider and that triggers the panic attack. With panic disorder, there's no external stimulus that's triggering the panic attack. And so understandably, people not knowing when it's going to happen, it's very unpredictable. They just randomly have this panic attack for no apparent reason. It starts to become debilitating and impacting when or where they will go out, and things that they may not do anymore because they're concerned about having another panic attack. And even with panic disorder, upwards of 90%, so less than 10% of people not responding to that exposure-based psychotherapy. Then with things like depression, less effectiveness, but still, maybe 30% of people don't respond to current treatments, and even a smaller amount of those people then have treatment-resistant depression, which means that they don't respond to a number of treatments. Typically, there's no standard definition. I tend to call it 3 treatments. So they've tried at least one evidence-based psychotherapy and 2 pharmacotherapies, 2 medications, or vice versa, something like that. Then with conditions like PTSD, estimates are up to 50% of people with PTSD don't respond to those first-line evidence-based interventions. And so that's really where my interest with MDMA came about, because that was my experience as well. A number of the people that I was treating were not responding well to the treatments. Some people would find the exposure process that we do for PTSD treatment to be overwhelming and want to drop out of treatment. Other people have ways of regulating themselves so as not to sort of put on a mask, I guess. So they're not really reprocessing. Like, it looks like they're going through the motions, but they're not really doing that. And that really accounts for that 50%. And ultimately, it depends on other things, So with substance use, for example, we know that prognosis is worse if you've got PTSD combined with a substance use disorder. Hence why I was seeing the poor outcomes where I was working. And as a consequence, there's quite a lot of variability in the estimates of how effective these treatments are. So anywhere between sort of 25 and 50% has been an estimate of the number of people who respond to the existing treatments. So 25% is very low, but it depends on how you measure response and the research methodology. So quite a large variation when it comes to estimates of PTSD. But that was really my interest in MDMA, was because this was one of the mental health conditions for which psychology hadn't yet developed a treatment that was good as our treatments for panic disorder, our treatments for depression, etc. This is an area where we need new treatments because the current treatments are not working for a number of people. And when that first-line treatment doesn't work, oftentimes they will be prescribed an antidepressant medication, which may treat some of the symptoms and provide some relief, but it's not treating the cause of the PTSD, which exposure-based CBT and EMDR and other evidence-based treatments, they're trying to address the root cause, and MDMA therapy is the same. It's actually trying to address the root cause rather than giving somebody something they have to take on a daily basis just to manage the symptoms, because essentially that's what I was seeing in substance use treatment anyway. That's why people were using the substances, for the same reason that they would be prescribed an antidepressant. Obviously, an antidepressant has potentially a lot less side effects and ideally is going to be less detrimental to the person's quality of life than psychoactive substances like alcohol are going to be. But ultimately, it's kind of the same thing. We're just putting a Band-Aid on it rather than fixing the problem in the first place.
Right, rather than going completely downstream to what was causing that mental health condition at the outset. I want to double click on psychedelic medicine. I think there'll be a range of responses right now running through people's heads who are listening. And there's a lot of stigma associated with these and perhaps some misunderstanding. You mentioned a term earlier, entheogenesis. And I know in your bio, there's a term in there, entheogen. And I had never heard of this before. What is an entheogen, and how, if at all, is it different to a psychedelic?
They are really one and the same. In many respects, initially when I entered this space, I liked the term entheogen because it had less stigma attached to it. Why most people don't, like yourself, didn't know what it was. So it didn't have the stigma that psychedelics have attached to it. Essentially, an entheogen is something that provides a spiritual experience from within, like endogenous, and theos, theological. So it's creating this spiritual and mystical state from within, which is one of the key aspects of a psychedelic experience. It creates mystical experiences which have been correlated with outcomes in treatment. So people who have a stronger mystical experience are more likely to get better. So there's clearly something going on there. But over the years, I think I've come back to embracing the term psychedelic and trying to reclaim it as a term to challenge that pre-existing stigma that's attached from the 60s and 70s. And so, when we set up Psychedelic Research and Science in Medicine, a not-for-profit company, is essentially established to get psychedelic research happening in Australia. We set that up in, I think, 2010, 2011, so it's quite some time ago, well before any research was happening. We thought it was best as a group to really reclaim the term and put psychedelic in our name. And I'm really glad that we did that now, because it does seem like the tide has turned and all of a sudden there's less stigma associated with psychedelics. Probably the opposite now. There's probably too much hype associated with them as potential treatments. And, they're being professed to solve everything from homelessness through to traumatic brain injury. So there's a lot of hype out there at the moment, which is a completely separate issue than the stigma itself.
So that stigma that you speak to, and perhaps we can step back to the 1960s and have a quick chat about where some of that stems from. I think that was something you touched on. I would listen to one of your TEDx talks, and I got a sense that you were frustrated by the stigma, which was perhaps getting in the way of research and funding for research and approval from ethics, right, to conduct studies. That was 2017. I think a year ago I had Professor Susan Rossell on from Swinburne, and we talked a little bit about MDMA and Psilocybin and some of the new research that had been published and changes with the TGA scheduling of these drugs. Have you been happy with the progress of psychedelic science in Australia since 2017 when that TEDx talk went up?
Yeah, absolutely. The tide turned right at 2017. We reconvened in December 2017 at another Entheogenesis Australis conference, and had many of the people in the room who were in the room when we first established PRISM. We also had Ben Sessa from the UK, a well-known MDMA researcher. I won't list all of the people that were in the room, but essentially, one more, Rick Doblin was in the room. And essentially, we were sort of feeding back that we've been trying this for the last 7 years. We're pushing shit up a hill with a stick. We're not getting anywhere. And Rick Doblin was quite forthcoming and direct. He said, I established MAPS in 1986, and it took me 20 years to get the first clinical trial up and running. So what, you've been going for 7 years? Not his words, my words. Drink some concrete and harden up. But we also came up with some different ideas of how we could, different approaches we might not have thought of, and consequently, two things came from that. One was the St Vincent's psilocybin study, which has now been completed, looking at people with a terminal illness and providing sort of existential relief from their suffering, and also the MDMA trial that I'm overseeing here at Edith Cowan University, with the support of Prism and community donations that have come from Prism. That was essentially the start of psychedelic science in Australia. Pretty much 2018 onwards saw the start of psychedelic science in Australia, and it's really burgeoned since then with folks like Susan Rossell, Paul Lanatsky, running the Monash Lab, and other groups coming onto the scene. And I think we've got a very mature and a thriving psychedelic science community at the moment. Then things really changed in a dramatic way, again, sort of progressively, I guess, last year in February, and the TGA announced that they were going to reclassify MDMA and psilocybin as a Schedule 8 medicine for the treatment of PTSD and treatment-resistant depression, which makes us the first country in the world to recognise these drugs legislatively as medicines, in our medicines legislation, which is huge. But given that, as you were saying, 2017, nothing was happening in Australia. We don't have the experience that other countries have had. The US was doing research with psilocybin again back in 2006. MAPS have run 6 phase 2 clinical trials, 2 phase 3 clinical trials. There are so many therapists in the US who have been trained to do this, so that if this were to happen in the US, which it probably will this year, the FDA is likely to approve MDMA as a medicine. They're ready to hit the ground running. Australia was not ready to hit the ground running. And consequently, the legislative change came into effect on the 1st of July last year, and there's been recent media in the last week or two about the first person that's been treated under this scheme. So it's taken a long time for everything to come together. And the reason for that is we don't have the experience. We don't have training programs in place. We don't have the governance set up around how to manage this clinically out there in the community, which is very different to doing it in a clinical trial. And ultimately, I think the TGA was smart in their approach, in that they've made it very restrictive. It's hard for a psychiatrist to become an authorized prescriber. They have to first identify a patient, then develop a treatment protocol for that patient based on the literature and what's happening in clinical trials, get that approved by a Human Research Ethics Committee in Australia. So that in itself, that's a huge undertaking for a psychiatrist, who may not have research experience, which you need to be able to do this. And then you apply to the TGA to become an authorised prescriber, and then you have to figure out how to actually import or access the drugs. They're not these are not widely available pharmaceuticals in Australia at the moment. So there's a lot of barriers in place, but I actually think that's not such a bad thing, because we're not ready to hit the ground running and have this being prescribed at psychiatric offices around Australia. And ultimately, while I get that a lot of the excitement here is these are new promising treatments that could be effective, it doesn't overcome the problem we were talking about earlier with a 6 to 12 month wait list to be able to see somebody in the first place. So it's not fixing the problem, it's just putting another band-aid over here. And consequently, because there's been so much media hype around this, I'm genuinely concerned, given the cost at the moment of these potential treatments. So upwards of $25,000 per patient for one treatment, which is way out of reach for most Australians, particularly those with a mental health condition, that desperate people are going to do desperate things. And the more people in the community hear about this and realise that they can't access it because they can't afford it, or they can't access it because there's just simply not a clinic in their state yet, I worry that those folks will access these drugs illicitly, perhaps engage with underground shaman, underground healers that are operating all around Australia. And some of them are good quality people. They're doing quality control. I recently heard that one of the patients I had excluded from our MDMA trial went out to seek psilocybin in the underground and was excluded by the practitioner. So, clearly they were doing some quality control, but it's Russian roulette. There are some very problematic practitioners out there as well, and there's been reports of sexual abuse and all kinds of things happening there. So, from a harm reduction perspective, it's not a great idea to fill people full of hope, then tell them that they can't access these things because they will go out and find other ways to access them. Desperate people will do desperate things.
Yeah, well, it seems you kind of need people working at both ends. What the science, looking at new tools that can be effective, and then at the level of accessibility in order to kind of to get these things out to the community and be used in the right context. Remind us how successful or effective are drugs like MDMA and psilocybin, specifically speaking to those two because they're the ones that the TGA sort of rescheduled. But how effective are they for people who are deemed to have treatment-resistant depression or PTSD?
The short answer is we don't know, because there's a number of problems running clinical trials with these drugs, and consequently we're seeing inflated or exaggerated benefits at the moment. Some of these problems are not being able to blind people. So normally when you participate in a randomized controlled trial, you're either allocated to a placebo group or the active group. If you're in the placebo, well, it doesn't matter what condition you're in. If you are administered MDMA in a clinical setting, within about half an hour, you're going to know which condition you've been allocated to, and so are the therapists and everybody else involved in the study. So you can't blind people to what they are receiving, and this is a problem that we haven't really overcome in research yet. The rates of blinding are not good. So when they do actually measure whether or not people can correctly guess what condition they are in, it's about 97, 98% of people guess the correct condition because it's pretty obvious. And the reason this is a problem for estimating the effectiveness of the treatment is because there's so much positive information out there about these treatments. People are coming in with a lot of hope and a lot of expectation. And so if they are put in the psilocybin or the MDMA condition, fantastic. But given the nature of the placebo effect, if they expect this is going to be a very effective treatment, then it's going to impact the effectiveness of the treatment. In the same way, if you give someone a sugar pill and tell them it'll stop their back pain, it will stop some of their back pain. And then if you're in the control condition and you think this is the end of the road, this is your last chance to recover from your mental health condition, and you realize you're in the control group and you're not going to get the treatment, well, that's going to mean that your symptoms are going to get worse. And so you end up with the people in the control group, ending up reporting worse symptoms, people in the intervention group reporting even better symptoms than we would expect, creating a bigger divide. An inflation of the effect size is technically what it's called. I was thinking at one point when we were talking about the underground practitioners and what's going on there, and you sort of summarized it saying there was, that you need both ends. You need everything in here. For me, that sits really well with me because, as somebody that's against prohibition and, pro decriminalisation and other ways of dealing with the drug issue, I don't have a problem if folks in the community want to go out and take a psychedelic drug or take any drug for that matter, provided they're not harming anybody else. That's fine. That's essentially, it's called cognitive liberty, being able to think and change your mindset in any way you wish. But this gets a lot more complex when we add in mental health, because the way in which these drugs work, they're experimental treatments at best at the moment. And so doing that in an unregulated environment outside of a clinical trial means that there's less control. And ultimately, if things do go pear-shaped, the person has got nowhere to report that to. You can't ring up APRA, who regulates all of the healthcare professionals, and say, this shaman needs to be deregistered. And I think the local Australian psychedelic community is really working hard at the moment to try to create a sort of self-regulation system so that there's support systems in place for people accessing these services, and they're able to report back, and there's sort of a a community-based feedback loop to try to stamp out some of the problematic practices and practitioners that are out there at the moment. But yeah, it creates a quandary for me, because on one hand, I think anybody should be able to do what they want when it comes to a drug. The drug shouldn't be made illegal. Yet on the other hand, once we insert mental health and call these mental health treatments, then the whole situation gets a whole lot more complex.
So it's difficult for us to quantify how effective these drugs are. Seem to be effective at some level, but you mentioned there it's hard to kind of tease out the placebo effect from the effect of the drug itself. How is it thought that these drugs, MDMA, psilocybin, are influencing physiology and leading to some type of benefit?
So MDMA is not a classic psychedelic. In fact, I wouldn't call it a psychedelic, full stop. We talked about entheogen. One of the terms that I like that's not particularly popular in the mainstream is entactogen for MDMA. It's something that it's an empathogen, an entactogen. It creates empathy, but it's very different both in its subjective effect and also the way it works on the brain. Very different to classic psychedelics. So classic psychedelics, including psilocybin, LSD, mescaline, dimethyltryptamine. I'll stop there, but could keep going on. All of the classical psychedelics primarily work at a serotonin receptor site called the 2A receptor, and it's thought that many of the effects are due to the binding at that site, and it's probably a bit more complex than that, because there's the odd 5-HT2A receptor agonist that doesn't produce a psychedelic effect, and there's research underway at the moment to create non-psychedelic psychedelics. So these are drugs that work the same way in the brain but don't actually produce the psychedelic experience, because understandably that could be a promising treatment. Many people, even who are desperate for relief, will be unwilling to go through the psychedelic experience because it's very unpredictable, that you can experience heaven and hell all within the same 5 minutes, and that can be quite uncomfortable. So the idea of having a non-psychedelic psychedelic treatment, I can see why that's appealing. Personally, I'm not sure it'll work, but that's currently under investigation. Not sure whether human trials have started with any of those new chemicals yet. And at a broader systems level, what the classic psychedelics are doing, possibly through that agonism of the 5-HT2A serotonin receptor site, is turning or dialing down the default mode network. So the default mode network is it's basically interconnected parts of the brain, and it's the default mode network. It's a bit like a brain conductor. We have multiple networks that are similar to this, that are like conductors of the brain. And so it keeps everything sort of in sync, all of the different parts of the brain that it connects up with. And if you turn off the default mode network, then it creates a cacophony of noise, because the systems aren't all in sync anymore. And it's hypothesized that the noise that's created by that dialing down of the conductor results in people being able to perceive themselves and their situation very differently. Like it allows them to think outside of very rigid beliefs that they might have, say with somebody with depression or a body dysmorphic disorder. And it may also explain the mystical experience that people have, sort of that crosstalk that's happening in the brain, whereas MDMA doesn't operate on that receptor site at all. It tends to dial down the limbic system, which is the part of the brain associated with fear response and other emotions. It allows people to sit with unpleasant emotions that they might not typically be able to sit with, and explore those, which for somebody with PTSD, they may not have ever been able to talk about the trauma. So they can't do talk therapy if they can't talk about the trauma. MDMA helps people work in what's called a window of tolerance. The window of tolerance is not being hyper-aroused and being overwhelmed, but not being able to use your masking response either, and being forced to experience the emotion as well. So they're able to experience it in a way that allows them to basically to work through the trauma and process that trauma. And it also, unlike classic psychedelics, MDMA really creates a sense of trust. So, which is really helpful in therapy as well, because we know the best prediction of whether somebody does well in a psychotherapy, it's not what psychotherapy they receive. In fact, it's whether there's a good therapeutic alliance between the clinician and the patient. If you've got a good therapeutic alliance, regardless of what approach you're taking, you're more likely to get a positive outcome. So by enhancing trust through the drug-assisted sessions, that in turn too is likely to enhance the therapeutic alliance and result in some of the clinical outcomes as well, be responsible for.
That's very well explained. I've heard stories of people hallucinating like they're on DMT during a deep meditation or during specific breath work. Is it possible that we can tap into these kind of same benefits that psychedelic medicines like psilocybin may provide through deep meditation or specific breath work like holotropic breath work, for example?
Yeah, absolutely. In the 60s, when, or maybe even earlier, the late 50s, particularly when philosophers like Aldous Huxley were starting to experiment with mescaline, some of the naysayers said that it was a shortcut. Essentially, people that are doing the work with various meditation or other contemplative practices like yoga, they're climbing the mountain the old school way. It's hard work, and when they get to the top of the mountain, they appreciate the view because they've done the work to get there. Psychedelics are essentially a helicopter ride to the top. You get to see what's up there, and then you drop back to the bottom again. Now, I like this analogy, not so much because I'm a naysayer, but I think a lot of people struggle to engage in those contemplative practices for long enough to ever get to the top of the mountain. And so I think being able to get a snapshot of what it looks like up there may provide encouragement to continue to engage in those contemplative practices and get the benefits from that.
Is there something at all to be said? And I'm not sure where I sit on this. I kind of haven't really made up my mind and I don't know enough about it. That's why I'm asking you. But is there something to be said about gaining mastery through years and decades of mindfulness where you slowly learn about yourself and have time to kind of come to terms with parts of yourself and the world where the mind has enough time to kind of adjust and mature versus just being thrown into this acute situation where you're sort of bombarded with a whole lot of new ideas and thoughts in a fraction of the time?
Yeah. And I think ultimately we need to ensure as we move forward rolling these out as treatments that these things are being paired together. I think they go together quite well. And I think the practice and the discipline and dedication that comes with these contemplative practices is useful for people having a psychedelic experience. Like doing that work beforehand is going to make the journey a little bit easier. I guess what I was saying with the mountain is some people get frustrated with the progress that they're making, and I think that's where psychedelics can augment the progress by just giving them a snapshot of what they could achieve if they continue to engage in these practices. But there's a lot of similarity between deep meditative states and a psychedelic experience.
What was it that kind of delayed Australia's progress in psychedelic science? So thinking back to that 2017 talk that you did, what are the types of things that got in the way and kind of inhibited progress in that area and perhaps could be kind of key learnings, I guess, for the scientific community abroad with respect to, not delaying potentially very helpful therapies for patients, across the spectrum of conditions that exist in the future?
Yeah, I think it's a lot of Australian culture and not just the broader Australian culture, but also academic culture in Australia. ultimately in academic culture, if you want to become a professor, the fastest way to become a professor is to do your PhD with a large research group or a lab, and from there do postdoctoral work with that lab, because they'll be producing hundreds of papers, and you'll get your name on all of those papers. The least effective way to do it is what I've done, which is to go out and try and do your own thing and try to set this up from the ground up. It's not I don't recommend it if your goal is the promotion pathway in academia. And related to that is the fact that we were struggling to get senior academics on board with this idea in those early days, because now with people like Susan Rossell supporting this, and other researchers around Australia that are senior researchers, it's a game changer. And in terms of why, with say mid-career researchers. Back in 2010, I was an early career researcher, barely even, because I hadn't finished my PhD yet. So I was speaking with mid-career researchers, and many of them would say, "This is a good idea. We should do this," but there's no way I'm doing it. There's no way I'm putting my head above the pulpit. And so they would have quiet conversations with me about how it was a great idea, but there was no way publicly that they were going to do anything with it, because this is the broader Australian cultural part. I think there's within our culture we have tall poppy syndrome, and the best thing to do in Australia to get on with things is to not stand out, is to conform, and hence why some of those mid-career researchers weren't willing to put their head above the pulpit, because they were worried, like a tall poppy, that they would get cut down.
And does that stem back to stigma with regards to the use of psychedelic medicines, and perhaps misuse, and perhaps some of the history going back to the 1960s with Timothy Leary at Harvard?
Well, yes. But there's also something unique about the Australian culture, because this stuff, this research was already underway in the US and the UK and the Czech Republic, all over the world. This stuff was happening, and we still didn't have anything happening in Australia. And I think that was the Australian cultural part. Something I realised. I was actually doing a podcast several years ago, probably around 2016, 2017, with somebody from the UK. And I said to him that that Australians are actually a very conservative people in general. We see this at the moment with the pill testing debate in Victoria and other issues. In general, we tend to be very conservative. And this podcaster from the UK was quite taken aback by that, because all of the Australians he met had been very progressive. But of course, they're the Australians that are travelling overseas, and so you're not getting an accurate representation of your average Aussie. And so I thought that was I found that quite eye-opening to sort of realise how conservative we are, and the way that feeds into the tall poppy syndrome. In terms of the stigma, at an academic level, it was less about stigma per se. It's something more deep-seated than stigma. Essentially, since in Australia, since the 80s, possibly the 70s, I can't go back as far as that, but essentially since the 80s, drug research in Australia is focused on pathologizing drugs. So drugs are bad, drugs are harmful. We need to demonstrate evidence for why we need to have them why we need continued prohibition of these drugs. And 99% of government-funded research was research that was focused on demonstrating these harms. But when we look at the problem with this is, as a drug researcher myself, the problem with this is when we look at the population of people that are using any given drug, most people actually don't experience harm. Most people are experimenting or using in a very recreational way in which they're not experiencing harm. It's only the very pointy end of people that experience harm, and even less people who become dependent on any given drug. So by focusing on the 1% that become dependent, that's actually not a stat, depends on the drug that we're talking about. But if we're focusing on that pointy end, then it means we're failing to understand what's protecting other people from getting to that stage. So I hope that with the way that we're thinking about drugs now as potential medicines rather than just drugs, that it might open up more research into understanding resilience and understanding what it is that allows people to use drugs without experiencing harm and without experiencing dependence.
Do you think that sort of more conservative approach or viewpoint is the logical viewpoint? And I say that with respect to the typical person and the media that they're exposed to. So what I'm getting at here is, are we extra conservative because of the way that our media has portrayed drugs across society?
Yeah, it's an interesting question, because basically what you're kind of asking is media reporting a reflection of society? Is it a mirror that's sort of reflecting back to society, or is the media is it sort of the reverse causation where the media are influencing the way we think about things? And I think it's probably a bit of both.
What would you say to someone who is just extremely skeptical about the use of psychedelic medicines? Perhaps they're thinking, okay, so there's people with mental health conditions that aren't being helped or completely helped. I understand that with the current treatments that are in the guidelines. These people need help, but they are also a very vulnerable population that might find themselves jumping at whatever is being offered to them as a kind of solution. And this is kind of the way that snake oil salesmen are able to kind of come in and capture a market. Western medicine isn't providing a sort of robust, effective treatment plan for a segment of the population, and they go looking elsewhere.
I would say that's healthy. I think it's healthy to have some skepticism. And what concerns me as we continue to move forward in Australia is people moving into this space that are overhyping the situation, that are ignoring the potential harms, because that's not helpful from my perspective. I'm increasingly being called a skeptic myself, and I'm somebody that's been working in the area for a long time, but I would say I've got a healthy level of skepticism. Like we talked about, how many people, how effective are the treatments? We don't know. Not everybody you ask will give that answer. Some people would just give you the raw numbers without providing some nuance around why these numbers aren't actually particularly accurate. So, and our experience at Prism in the early days was the average member of the community did understand the difference between the use of these drugs recreationally and the use of them therapeutically. And we've sort of seen Australia mature a bit with medical cannabis. And so I think the broader community is already aware that these are two different things. So the stigma didn't seem to be coming from the community at large. It was more to do with the academic institutions within which we were trying to embed these research projects. But ultimately, yeah, a bit of skepticism is healthy, and I think people should remain skeptical of these experimental treatments. Yes, Australia might be sort of leading the pack in terms of loosening the restrictions around accessing them outside of clinical trials, but ultimately these are experimental treatments. We don't know how they work. We don't know how effective they are. So yeah, I think if I was speaking to a patient, I would encourage them to be a critical thinker about the information they're looking at, and to ensure that they're able to make an informed choice, that their choice is informed by good evidence and not hype.
If someone is quite skeptical, and perhaps historically or previously they've thought of these drugs as disgraceful, or maybe they even think people that use them are a disgrace to society. I'm using language that I've heard in conversations. What types of questions should we be asking ourselves to be a little more open-minded here?
I'm not sure if I've got a good answer for that, but I've got a short story to exemplify what you're talking about. When I was I don't know, nearing the end of my undergraduate studies. I was at my father or my uncle's 50th, 60th birthday party, and one of my dad's friends came up to me and asked me what I was studying and what I was doing. And I explained, I want to become a psychologist and work with people. I help people who are experiencing problems with substances. His response was, I've got the solution for you, and it'll only cost 10 cents. It's called a bullet. And I didn't know how to respond to that, and I still don't. Well, I just feel like when you come across somebody like that, maybe you're not going to change the person's mind. It's like a conspiracy theorist. In fact, what you end up doing is further consolidating their own position by arguing against it. But, for people that are less entrenched in their views, opening up some conversations like we did at the start around the impact that alcohol is having on the community and the fact that alcohol is a drug. Most Australians don't perceive alcohol to be a drug. It's something different. It's not a drug. It's not a medicine. It's not a food. It's something separate altogether. And so, trying to open up some of those conversations, I think essentially that with somebody that is not entrenched with their view and that has some open-mindedness, it's about fostering curiosity so that they go away and do their own research and start to access some of that information themselves.
This is a little bit of a departure from your area of work here, but related to, I guess, some apprehension or resistance from the community towards psychedelic medicine. Have you ever given thought to the role of religion here? And my understanding, which is very high level, I'm not a religious person, but my understanding is that the Bible refers to mind-altering drugs as sorcery, and that if you practice sorcery along with other things like hatred and jealousy, which sort of are in that same section of the Bible, you will not inherit the kingdom of God. How much do you think religion influences the current narrative surrounding mind-altering psychedelics?
I think it has more of an impact when we're talking about psychoactive drugs in general. There's a moral narrative for which the church has a large voice. And it can go both ways. It can be that people are morally corrupt and that's why they're using drugs, or it may be that the drugs morally corrupt a person and then the drugs have the agency. But I think when we're talking about psychedelics, with some fundamentalist religious people, from all schools of religion, Islam, Christianity, that they will take a similar position to what you've said, because essentially fundamentalists are reading the text for the text. There's no assumed nuance or understanding of the historical context when these words were actually written. And there's also evidence in the Bible of psychoactive substance use, possibly psychedelics. So, for example, there's reference to manna, which some people have thought could be psychedelic mushrooms, even Amanita muscaria. There's a couple of books that have been written on this, looking at sort of the flesh of the gods and the way that psychedelics probably led to the inception of religion. So initially, in most religions, people would have been having a personal experience through using a psychedelic and experiencing God directly. And then over time, the way organized religion operates means that that people become the conduit to God. So you've now got a priest or minister that is the conduit to God. And I think the reason some religious folks that are even moderate religious folks would be concerned is, why go to church and use the minister as a conduit when I can take 5 grams of mushrooms and dial a direct line to God?
Yeah, that poses a bit of a moral kind of conundrum for someone to work through.
Likewise, I think a spiritual framework is actually important for people who are undergoing a psychedelic experience. In the first study of psilocybin since the 60s and 70s at Johns Hopkins, it was a requirement that participants had a spiritual framework to help them essentially frame their experience. So they've got something to hang the experience off. So I think having a spiritual framework is actually an important thing for people coming into a psychedelic experience. And many people that maybe come into the experience as an atheist come out of the experience at least agnostic. They might not be particularly spiritual or religious afterwards, but they're certainly more agnostic that maybe there's something more out there than just the material world.
Yeah, earlier you mentioned there's an association between a spiritual experience that's induced from a psychedelic and the efficacy of that treatment. We didn't double click on that. What is a spiritual experience?
So typically it's called a mystical experience rather than a spiritual experience, but basically one and the same. I'm splitting hairs here, but there are tools that measure these. So hence why we can look at the correlation between the degree of mystical experience and the degree of reduction in depressive symptoms or anxiety symptoms. It typically tends to be a sense of reverence, that this is something sacred that you're experiencing. There's a God, the words just fallen out of my head. I have trouble with this word, and it's quite funny because the word I'm trying to think of actually means that you can't put things in words, and I always get it confused with another word. And if that other word gets in my head first, then and now I've got ephemeral, and it's not ephemeral; it's the other word that won't pop into my head now. But yeah, essentially, people find that language alone is inadequate to describe the experience. There's a sense of oneness and connectedness, that all is one and we're all interconnected. They are the primary features of a mystical experience, and mystical experiences that contain those elements occur spontaneously without psychedelics in some people. Sometimes through a medical condition, certain types of epilepsy can produce these mystical experiences, and sometimes for no sort of explained reason. And maybe some of the religions, maybe some of them weren't due to people's psychedelic experiences, but rather these sort of spontaneous mystical experiences that people have.
I think that word that you were perhaps looking for is ineffable.
That's it, ineffable. I don't know why.
There we go.
As soon as I've got it there, ineffable and ephemeral in my brain just cross over for some reason, and it's very annoying for me.
What exciting psychedelic science is currently happening in Australia? You mentioned before it's experimental. There's still a lot more research to be done. What can we kind of expect to see be published in the coming years?
Yeah, so there's a couple of studies that are finished. It's going to be a while, I think, until some of the really interesting stuff is even happening in Australia. A lot of it's still in the very early stages. There's a project at University of Sydney looking at MDMA-assisted psychotherapy with people with PTSD that's comorbid with substance use. So that was obviously of interest to me, given the conversation we've had today. Also at University of Sydney, they're proposing to do a study using psilocybin to treat eating disorders like anorexia. In Queensland, there's a study looking at people with grief and using psilocybin as a way to assist with grief. I think that's sort of world-leading research as well. I'm not aware of other research with that sort of focus. There's research that hasn't commenced yet at the University of Melbourne, looking at MDMA as a potential treatment for people with young adults with autism who can currently experience social anxiety. So as a way to sort of treat the social anxiety among people with autism. I think that's fascinating as well. And partly the reason there's so many interesting projects that are sort of almost up and running or have just started is a couple of years ago, the federal government put $15 million out to tender through the NHMRC, and a number of the projects that I've just mentioned were recipients of a small part of that funding, and as it allowed some of the very novel research that's happening in Australia. Essentially, the funding program that the government allocated this $15 million to was for novel research projects. So not just replicating what's been done overseas already, but doing something quite unique and different.
So there's quite a few different studies, but probably 5-10 years away, I guess, from getting results from many of those, with how long the trials take and then analysis of results. Have you given thought to what the future might look like here for a person in Australia with a mental health condition that is resistant to psychotherapy? What do you think the treatment paradigm will look like in 10 or 15 years from now?
Well, I think as we were talking about, we need to first address the issue of supply. And one way in which this might be addressed with the psychedelic treatments and MDMA treatments, probably more so with psilocybin than MDMA, is stepping away from requiring clinical psychologists to provide parts of the treatment. Because with psilocybin, it's a sort of a 6 hour session, and if you've got two clin psychs or possibly a clin psych and a psychiatrist in the room, that's very expensive. And to be frank, I don't think you need that level of expertise in the room, because when somebody's under the influence of psilocybin, they struggle to talk. They just need some reassurance, someone to hold their hand. It's really just it's trip sitting is what we do in the harm reduction community. There's services like Dancewise that have been offering trip sitting services for 20 plus years at festivals in Victoria, and other states have similar services. And those folks that are providing the trip sitting aren't mental health clinicians. They are peers who have had their own experience and understand how difficult that can be, particularly in a festival environment, and are able to just hold space with somebody so that they feel safe and communicate that the effects, you're feeling this way because you've taken a drug, and the drug effects will wear off. We just need to wait it out, and I'm going to be here with you to help you wait that out. So I think we're going to have to look at different models of treatment provision to overcome the issue with a lack of supply of mental health clinicians. Another novel approach might be group therapies, so dosing people, in groups of 5 or 10 or something like that. And of course, the research first needs to take place to see whether that's safe and effective. That hasn't happened yet. But I know that sort of research is underway elsewhere in the world. I'm not sure about Australia, but certainly elsewhere in the world, they're starting to investigate that, because other parts of the world they recognise that these are going to be treatments that are going to be mainstreamed eventually. So we need to, think about how we can do this economically, because, as we've said, $25,000 for a treatment is simply not feasible for most people. It's out of most people's reach. So we need to come up with ways of reducing the cost, and a key way of doing that will be through looking at the model of service provision. I think a number of countries are watching Australia at the moment, and they're going to learn lessons from what we do wrong as they move to implement this as a mainstream treatment. So lots of eyes on Australia at the moment to see what works well and what doesn't work well. And ultimately, we need to sort out the supply issue. And I don't know what the answer to that is, but that seems to be one of the key issues here.
Hey friends, are you ready to take your fermented food game and gut health to the next level? Look no further than my digital guide, Plant-Based Ferments. Inside, you'll discover some of my favorite recipes, including my soy labneh and homemade kombucha. Visit theproof.com/ferments for more details. That's theproof.com/ferments. Okay, that's enough from me. Let's get back to the episode. Do you think, with your understanding of psychedelic science and also of drug use and drug-related harm, that if we are able to achieve those things and improve access to various psychedelic medicines and other compounds like MDMA, that we would see a significant reduction in substance use disorders in Australia and drug-related harm?
No, I think the cause of many of the problems with mental health and substance use are what are called social determinants. They're things in society that predispose people to experience mental health conditions. It's to do with increasing divide between the wealthy and the not wealthy in Australia, homelessness. The psychedelic treatments are not going to fix the homelessness problem. As I said, I've seen CEOs of companies overseas, saying that they're going to fix these problems with psychedelics. Psychedelics aren't the answer to homelessness. Homes are the answer to homelessness. So there's lots of problems in society that are addressable, because essentially what we do most of the time in Australia when it comes to mental health is people fall off the cliff, become unwell, and there's an ambulance at the bottom that cuts them off to treatment. There might be a wait time and ambulance queuing happening because of the supply issues, but essentially people are falling off the cliff and the ambulance picks them up at the bottom. It would be far better to build a fence at the top of the cliff with a sign on it saying dangerous, don't fall off, rather than just continuing to pick people up that fall off the cliff. And I think that's like the supply issue with mental health. It's a far more wicked problem. It's a far more difficult problem to address, because governments are quite short-sighted. They're focused on being re-elected, and a lot of these things are not necessarily popular with all voters, and it takes time, years, for us to see the benefits of some of the changes that could be made that we know would reduce the incidence of mental health in Australia.
So that fence represents, sorting out some of these inequities that exist across society and other things. Most of what we've been speaking about is the use of certain compounds, MDMA and psychedelics, for people with mental health conditions. What about keeping people from developing mental health conditions in the first place by using these compounds? In other words, is there any evidence to suggest that the incorporation of such compounds can help with the erection of that fence that you're talking about?
I'm not sure there's much good evidence for that. There's certainly a lot of hype around microdosing. That was the first thing I was thinking of when you were sort of talking there. But it's not even clear whether microdosing is more than a placebo effect at the moment. The evidence is very mixed. And outside of that, again, I think it's the structural changes that are going to see far more impact on the incidence of mental health than psychedelics could ever do. Maybe the way in which psychedelics help here is indirectly. One of my honours students, for example, looked at the degree to which people have had a psychedelic occasion mystical experience in their pro-environmental behaviour, because there's an assumption that people that have had a strong psychedelic experience are going to be more caring of the environment because we're all one, etc. And she found some evidence that supported her hypothesis. So and I guess in my informal conversations with Kelly, my student, I was very much of the position that psychedelics are not going to fix the world's climate problems, but through those informal conversations, I guess I've softened a bit to see how if more people have had that experience, then the conversation more broadly becomes easier to have because more people are on the same wavelength. And I think with mental health, maybe it's the same. If more people are sort of progressive in their thinking as a result of having a psychedelic experience, then that could lead to those social structural changes that are required to decrease the incidence.
Yeah, that would be an interesting study design to contemplate. Just try and tease that out. Where does decriminalisation fall within the list of possible things that may reduce drug use or drug-related harm?
Well, it's the easiest thing that we could do right now. That would have a significant impact on drug-related harm in the Australian community. In Western Australia, where I'm currently based, cannabis was decriminalised. I can't give you the dates, but 15, 20 years ago, cannabis was decriminalised here. There was no increase in crime. There was no adverse effects from it. But then a Liberal government got in and sort of rescinded the work that the Labor government had done and overturned the decriminalisation despite no evidence that it had caused any harm. But there was evidence that it was actually having a benefit, though, because if you're a young person and you get caught with some cannabis, you're charged and now have a criminal record for possession, that then has an impact on your developmental trajectory and what you are able to do or believe you're able to do after that. And, like somebody who's been on a diet and has a hamburger out of the blue, there's you kind of go, screw it. I've already had the one hamburger. I might as well just give up on the diet now. Screw it. I've already got a criminal record. Who cares anymore if I get more on that criminal record because I've already got one. So, I think decriminalisation is a sensible first step to take, and it will have an impact on all of the different drug use communities that exist within Australia, including the underground scene that I was talking about. I think if you're an underground practitioner and something goes terribly wrong with somebody, because you have supplied an illegal drug and you're essentially then seen by the law as a drug dealer, you're going to be far less inclined to ring an ambulance, or maybe there's a delay in seeking help. Whereas if things are decriminalised, then it allows us to be a bit more open about some of these conversations, and there's less, less trying to hide what we're doing. And that's an issue with other drug use as well, where people are trying to hide their drug use. I think if we can be more open about it, we've seen this in Portugal where their education is very it's an adult-to-adult conversation, and because it's all been decriminalised, that they're able to have far more frank conversations, and consequently, young people there are less inclined to use drugs because they've had the opportunity to have those open conversations.
Yeah, what are the major takeaways from Portugal? From my understanding, they had a very large heroin kind of crisis problem back in the 1990s, which then led to decriminalisation. What's happened to heroin use and drug-related harm in Portugal?
It's decreased. So, well, it's more nuanced than that. There's been a slight increase in drug use in Portugal, but there has in other European countries as well. And the increase in Portugal is significantly less than other European countries. So in some ways, we can say there's been a decrease in drug use sort of at a net level. As I say, drug education has changed there. I think that they really have generated a lot of evidence for the rest of the world to say, regardless of whether or not it reduces harm, what we can confidently say from Portugal is if we decriminalise, more people are not going to use drugs and more people are not going to experience drug-related harm, because that's one of the arguments. I mean, we've seen decriminalisation recently in the ACT, and Michaelia Cash standing up in Parliament talking about everybody going to Canberra now to use cocaine and ecstasy and everything else. That's ridiculous. That's not going to happen. People aren't going to. Canberra's not going to become a drug tourism destination just because drugs are decriminalised there. It would be different if they were legalised and being sold from shops, but that's not the case. I think there's a lot of conflation in the community around decriminalisation and legalisation, and not understanding the difference between the two.
Yeah, so perhaps we can kind of underscore that. So decriminalisation is, in the ACT. The Australian Capital Territory here, where Canberra is, if I was walking around the streets and I got caught with, a gram or half a gram of cocaine, or there are, other drugs that are on that list like heroin or psilocybin, there's varying amounts, I understand. But if I was caught with that amount or less, rather than that being illegal and me having a criminal record and perhaps facing jail time, I would be fined without a criminal record. Is that what happens?
Yeah, so there's the nuance here. So it is still illegal. So the drugs are still illegal, but the way it's being treated is through a different process. So rather than it being a criminal offence, it now becomes a civil offence. A good example, a good analogy is speeding. If you get caught speeding, provided you're not doing 300 kilometres an hour, it's treated as a civil offence. You get a speeding fine and you pay the fine, but it doesn't go on your criminal record. So it's treating drugs in the same way that we treat traffic offences.
Got you. So you're still breaking the law. You're just not criminalized for that. And legalization would be making the production and supply and retail of the product legal.
Correct. Well, there's even a nuance to that. So in the ACT, they've kind of legalized cannabis, but they haven't legalized cannabis. So you're allowed to legally grow, I think, 2 or 5 plants in your home. You're legally allowed to carry an ounce of cannabis on your person legally, but you cannot sell it. Selling it is breaking the law. And even swapsies is prohibited as well. You can't swap it or barter or anything like that. So I think I really like the ACT, not only because it's the most progressive state or territory in Australia when it comes to drug law reform, but also because it allows us to have these nuanced conversations around what is legalisation, and that you can see that it's a continuum from prohibition through to decriminalisation through to sort of the ACT type legalisation through to what we've got in the US with cannabis in most states now, where adults can purchase cannabis from a brick and mortar store completely legally. And even as we move up that last end of the continuum, there's various ways that can be done as well. So in Uruguay, cannabis is legal, and it can be only purchased from a pharmacy, and the cannabis is produced by the government. So there's not companies. One of the problems in some US states is capitalism has got hold of this now, and it's typical capitalism. There's advertising and sales and everything that comes with that. Uruguay has really clamped down on that. Places like Spain have cannabis clubs, so it's a bit like the ACT, but you're allowed to do swapsies. No money can exchange hands, but you can swap plants and things like that. And even looking at the US with their legalized model of cannabis sales, there's big differences depending on which state you're in. Some states allow for it's basically open slather, whereas others have restrictions on advertising, restrictions on how much you can sell to people, and those sorts of things. So I think in particular with cannabis in Australia, the question isn't should we legalise cannabis or not. The question is what's the best model of legalisation that minimises harm best.
Does the decriminalisation of drugs, so what ACT have passed, the legislation there that's been passed, does that lead, or is there any data showing that leads to less money being spent on enforcement, and therefore more money can go into healthcare and education to kind of reduce demand?
I don't think we're there with the ACT yet, but certainly in other jurisdictions like Portugal, yes, they've demonstrated a significant saving from the supply control efforts, essentially the law enforcement efforts, and that money has been diverted into not only education but treatment and rehabilitation. One of the things that's made the treatment services work so well in Portugal is because they've been able to shift that money from law enforcement to treatment and rehabilitation. In Portugal, when somebody's exiting a treatment service, they are offered a job in a different geographical region, because we know people are more likely to relapse. Of course, people relapse if they're using heroin in a house with 4 other people that use heroin. They go into treatment, they come out of treatment, go back into that house again. Of course they relapse. Like it's a no-brainer. The fact we even wonder why they relapse is a concern. So by placing them in a different geographical region, that reduces the risk of relapse. It allows them to create a new community of people who aren't using drugs. And the reason they can do this is they provide tax incentives to employers to employ people coming out of treatment, so that it's sort of a win-win situation. The employer gets a tax benefit from it, or essentially gets some money for it, and the person coming out of treatment has a job, which is really important for meaning and everything else that we know is important for recovery. And on top of that, they're moving to a different area, so they're not going to have all the same contacts.
How long do you think until we know that the new legislation in the ACT has been successful in reducing crime, drug use, overdose, etc.?
Yeah, it's going to take a little while to do that. The easier thing to show is that it's not causing more harm. It will take a bit longer to then show how harm may have been reduced and what sorts of harms have been reduced.
Where do you sit on the kind of spectrum of legalization versus prohibition? Is there a world where legalization may actually result in less drug use and less overdose?
Yeah, I think it's complex and we don't know the answer to it, but I think it is absolutely possible. And it depends again on the model of legalization. So it's not about whether we legalize and regulate, it's about how we go about it. And so I think um, I think one possible model is to regulate the drugs dependent on potential harms, potential for dependence and things like that. So maybe if we legalize all drugs, maybe you could access heroin, but you have to go to your GP to get a script. And you can only get it from the pharmacy. Maybe MDMA is over the counter in a pharmacy, and there's only one brand that's produced by the government, no advertising, etc. And I think if we lived in a world like that, we would see less use of drugs like alcohol. And given alcohol is probably one of the worst drugs that we could possibly use as humans, it's neurotoxic, it's toxic to the liver, causes liver damage, it causes several cancers. It's just a terrible drug to be using. It's when we talk about most drugs, we talk about you said half a gram of cocaine. That's more than one dose in half a gram of cocaine. When people are drinking, one standard drink is 10 grams of ethanol, and 10 grams of ethanol doesn't really touch the sides for most people. So when you're getting a bit of buzz, you're having 40, 50 grams of alcohol. There's no other drug that we take in such large quantities for a psychoactive effect. And so, if less people are using alcohol and because they're using drugs like MDMA instead, then physically we'll see less harm. But also, the nature of alcohol in terms of the way it disinhibits people and increases violence. If you see two people out in the street having a fight, and you had to guess which drug they were on, are they on alcohol or have they taken MDMA? Certainly not MDMA if they're punching up.
I'm not sure the alcohol industry would love the sound of that.
No, I've got a I think it's actually a meme that I use in some presentations. I don't think it's a real sign, but it's a mock-up of a Budweiser ad, Budweiser billboard saying, don't use drugs, that way you've got more time to drink alcohol. The alcohol industry absolutely has a vested interest here.
How would legalization affect the kind of underground production of these drugs, and I guess an entire industry where there's a lot of tax that's not being collected, for example?
Yeah, so it's unlikely to eradicate the black market. Look at tobacco. There's a black market for tobacco in Australia because taxes become so high that it creates a place for a black market. So I think there will always be a black market, even with various models of regulation. And we've seen this in the US, in states with cannabis, where there's still a black market for cannabis. Sometimes even synthetic cannabis, because it's so cheap. It's been sort of sold to vulnerable populations as a cheap drug that they can use because it can be produced far cheaper than the legal cannabis that's available from dispensaries. So you'll never eliminate a black market, but it will certainly put a huge dent in it. We talked about the alcohol industry having a vested interest in maintaining the status quo of prohibition. The criminal syndicates have a vested interest in maintaining the status quo as well, because Australia in particular is such a lucrative market for them to be working in. They're making billions of dollars through importing drugs into Australia and wholesaling that, and then profits that get made down the line as people on sell.
Stephen, this has been Fascinating. Super, super interesting. I'm fascinated by how this is going to play out over the next 10, 20, 30 years from a legislation perspective, from a science perspective on novel compounds for different conditions. So thank you so much for taking the time to join us today and all of the wonderful work that you're doing. Was there anything that you wanted to add or something that perhaps we missed that you wanted to kind of touch on before we land this plane?
No, but I think, just as you were sort of saying, it'd be interesting. It will be interesting to see how things sort of play out over the next 20 or 30 years. I really hope that in 30 years from now, the community looks back at what we were doing with regard to prohibition in the same way we look at other things in history and just wonder how could we be so barbaric as to think this was a good solution. I hope that's where we're at in 30 years from now.
Are there any books or resources that you might recommend if someone's interested in decriminalisation or prohibition, whether it's a book or a documentary, something that we can kind of point them towards?
Probably my first recommendation would be Chasing the Scream. I want to give the author's name, but I've got a feeling I'll get it slightly wrong. And there may have even been some sort of a documentary series developed around that book. That's a really good resource to understand in a very accessible way how we got to the situation we've got now. Because people often assume prohibition is something that's been with us forever, but it wasn't that way. Heroin was a prescription drug up until the 1950s when Australia had the highest per capita rate of heroin, and the government fixed that by prohibiting it. Prohibition is actually a fairly new experiment, but we just assume that's the way things have been forever, and they haven't been that way. There's a book on methamphetamine by Matt Knopfs, which sort of provides a similar picture, but more localized to Australia. So Chasing the Scream is by Johan Hari, who's from the UK, whereas Matt Knopfs is from Sydney, and so I guess that's a local narrative. And sort of looking at the Australian, it's fascinating. Looking at the Australian history through colonisation and the way alcohol has become so intricately embedded and woven into society that it's, you really notice it if you stop drinking for a while, if you do Fed fast or something like that. That's when you realise just how deeply intertwined alcohol is in our culture.
Did you say there that prohibition reduced heroin?
Yeah, it did, because prior to that, you could get it, might have been even over the counter at the pharmacy. So instead of being able to go down the pharmacy and pick up your heroin like you could in 1951, in 1952 they just banned heroin, which meant you couldn't go to the pharmacy and get it anymore. So of course that's going to lead to decreased use, and presumably GPs would have then had to prescribe some people other opiates to use as a replacement to prevent them from going into opioid withdrawal, which is what we do with methadone and buprenorphine and drugs like that at the moment. But yeah, it's essentially, it's complex with prohibition and rates of drug use, because the concern from prohibitionists is that if we lift prohibition, everybody's going to go out and use drugs, and I don't think that's going to be the case, and it's not what we've seen overseas. Rather, it's more complex. Yes, there might be an increase in some use and a decrease in other use. What's really important is not the incidence of drug use, but the incidence of drug-related harm. And if we're decreasing drug-related harm, that's the important thing.
And you're of the view that if done correctly, moving from prohibition to legalization will result in less drug-related harm.
Yeah, less net harm, overall harm.
Brilliant. Thank you so much, Stephen. Where's the best place for us to send any of the listeners that want to connect with you online? Is it Twitter?
Used to be. I've since Elon Musk taken over, I've kind of tried to. It's a bit of a dumpster fire there now. I have an account there. People are welcome to send me a DM. I'll be a bit slow on the response time. I've transitioned to LinkedIn as a safer place to interact with people in a post Elon Musk X world. So that would be the best way to directly communicate. If you're interested in some of the work that I'm doing, my ECU profile's sort of got papers that have been recently published. I've mentioned psychedelic research in science and medicine, so prism.org.au. Recently became involved in Psychedelic Institute Australia, which is more for healthcare practitioners that are wanting to engage in training, and we're working with the Australian Psychological Society to develop accredited training for therapists wanting to work in this space. For folks that are interested in drug policy reform, I'm on the board of Students for Sensible Drug Policy. I'm a huge advocate of what Students for Sensible Drug Policy are doing, both here in Australia and also internationally, in terms of giving young people a voice to question the status quo and giving them the courage, skills, and what they need to be able to make submissions to Parliament, give evidence to Parliament. I've had former students give evidence to WA Parliament. And finally, I don't do much in this space anymore, but I found 2016, I founded Alcohol and Other Drug Media Watch as a sort of a watchdog for media reporting. And I'm just stretched too thin these days, and I've had to prioritise what I can do and what I can't do. And they're not really doing a lot in that space at the moment, but AOD Media Watch is on LinkedIn, Twitter and Facebook.
Great. We can put a link to all of that into the show notes. Thanks again. It's been a real delight to have you with us today. There you have it, friends. I hope you enjoyed this episode. If you did and want to stay up to date with future episodes, be sure to hit that subscribe button on YouTube and follow on Apple or Spotify. Finally, thank you for showing up and the effort that you're making to take control of your health. I look forward to hanging out with you again in the next episode.